Hello, good afternoon, everyone. I welcome you all to yet another session of Indian Fertility Society. So, for today's session, we are having Dr. Aparna Sharma with us. She is a MD, DNB, FICOG, MNEMS. She is an additional professor, also the Division of Maternal Fetal Medicine, Obstetrics and Gynecology, AIMS, New Delhi. Fetal medicine specialist with expertise in fetal intervention. She has received a Kamini Rao Orator Award in 2017, Foxy Junior Creation Award 2018. Foxy's Son IACE International Traveling Fellowship 2019, Legend of Tomorrow Award NYZ Foxy 2019, Foxy's Imaging Science Committee Award 2019. She's also been the Joint Secretary Society of Fetal Medicine 2020 to 2022, North Zone Coordinator SIF Motherhood Committee Foxy 2020 to 2023, Co-Chairperson AOGD Quality Committee 2019 to 2021. She's also the co-convener Early Pregnancy SIG Indian Fertility Society. I hand over the session to Dr. Sharma now.
Hello, everyone. Today we will be talking about torch infections, the current perspectives. When we talk about infections in pregnancy, we have different types of infections. Some of them could be predominantly fetal infections, which cause congenital malformations, among which the torch group of infections are well known. Some of the infections could be both fetal and maternal infections like HIV, HBsAg, and HCV, while some of them could have predominantly maternal afflictions like the hepatitis E virus and influenza. Today we will be talking mainly about the torch infections which have the fetal afflictions. Recently, this document has come in 2020, and they have talked about the role of ultrasound in congenital infections. But eventually, this document is all about the diagnosis and management also. So, when we discuss torch, what we really need to know is that what are the effects of the infection on the fetus? What is the indication for torch testing? What workup should be done? The maternal workup. What should be the fetal workup? And what are the interventions to prevent? Hello, everyone. Today we will be talking about torch infections, the current perspectives. When we talk about infections in pregnancy, we have different types of infections. Some of them could be predominantly fetal infections, which cause congenital malformations, among which the torch group of infections are well known. Some of the infections could be both fetal and maternal infections like HIV, HBsAg, and HCV, while some of them could have predominantly maternal afflictions like the hepatitis E virus and influenza. Today we will be talking mainly about the torch infections which have the fetal afflictions. Recently, this document has come in 2020, and they have talked about the role of ultrasound in congenital infections. But eventually, this document is all about the diagnosis and management also. So, the effects of the infection on the fetus, what is the indication for torch testing, what workup should be done, the maternal workup, what should be the fetal workup, and what are the interventions to prevent or treat fetal infections in utero. So let us go step by step. And also we would be having a bit of a case-based discussion here. So here we have a 24-year-old primary gravida at 28 weeks periods of gestation. Otherwise, her antenatal investigations were normal and her blood pressure were normal. But her ultrasound findings at 28 weeks of pregnancy suggested fetal growth restriction, and there was oligohydramnios. Otherwise, there was no evidence of ecogenic bowel or calcification. Now, my reflection would be, and I would wonder, can this be explained by torch infection? So, we should first question should be, what are the possible effects of torch infection on fetus? So, torch infections can cause spontaneous abortions, preterm birth, intrauterine growth restrictions, structural anomalies in the fetus, stillbirth, low birth weight, and persistent neonatal infections. However, what we really need to know is that what are the actual indications for maternal torch screening during pregnancy. So we do come across rampant testing for torch in a lot of pregnancies, but we need to remember is that torch infections should be screened for in mothers for very, very specific indications, and which are when there are clinical signs and symptoms of maternal torch infection, like fever, rash, exposure, or contact, lymphadenopathy, unexplained hematological dyscrasias, ultrasound markers for congenital torch, like early onset fetal growth restriction or a severe early onset fetal growth restriction, symmetrical or associated sonographic markers like ecogenic bowel, calcification in brain, liver, or hydrops, or screening in targeted high risk groups. So that literally brings us to the fact that unless there is an indication to screen for torch, we should not unnecessarily order torch tests, because the interpretation and management becomes really confusing. So, coming to the next point, that which group of pregnant women are at high risk of torch infection? So, within the torch infection, the toxoplasma, the epidemiological factors for toxoplasma would be the people who are having a raw meat consumption, unwashed home garden products, exposure to cats in surroundings. While rubella, exposure to rubella infected patients, and CMV is the most common torch infection, and HSV, high risk sexual behavior. So, some of the epidemiological factors are these. For all infection, if prevalence of infection is high or endemic areas, these women would be at high risk. For example, France is a country where it is a high risk for toxoplasma and a routine screening is suggested. So then, while advising torch in certain situations, it is also important to understand what are the situations in which torch screening should be avoided. So, maternal torch screening during pregnancy should be avoided as a routine screen in all pregnant women. And we know about situations or conditions or setups where a routine torch screening is done in all pregnant women. Or for workup of recurrent miscarriages, please do remember that torch infections do not cause recurrent miscarriages. Also, may not be cost effective or providing a solution in pregnant women if the fetal growth restriction is isolated or late, or what we call an asymmetrical associated with uteroplacental insufficiency. So these are the situations in which you would not like to do a maternal torch screening during pregnancy. Now, coming to the role of ultrasound in the diagnosis of fetal infections. So, first of all, we need to understand that ultrasound is safe, it is least invasive, and yet a very effective way for detection of torch infection, also for monitoring and resolution. And sometimes there are a lot of non-specific findings which build up to the diagnosis of infection. And if there's a specific finding, we can identify the causative agent and correlate with the antepartum and the postpartum syndrome. So, coming to the first point, which are the non-specific ultrasound markers in torch infection in the fetus. So the non-specific ultrasound markers, so first we start with the cranial abnormality, which is ventriculomegaly, calcification, intraventricular synechia, cerebellar abnormality. So these are some of the findings which you can find in most of the torch infections. And the extracranial findings, as we discussed earlier, would be small for gestational age, hyperechoic bowel, hepatomegaly, liver calcifications, or there could be even placental and amniotic fluid abnormalities. So a symmetrical growth restriction with oligohydramnios, early onset, could be in the absence of Uteroplacental insufficiency could be one of the markers for torch infection, which we need to keep in mind. So again, coming to this point here, that is there a role of routine prenatal screening for torch in pregnancy, is something that we really need to look into. And why I am re-emphasizing is that there is a wide geographical variability, and it really needs to be considered. ACOG recommends screening for rubella at first prenatal visit, and IgG only is recommended and alone is sufficient to establish immunity. So if IgG is positive, we know that the patient is rubella immune and we need not worry about rubella infection. Now, if IgM is positive, then it should not be done alone, because IgM is suggestive of acute infection, and sometimes it is false positive also. So we should also always combine IgM with IgG. So if possible in our settings also, rubella is something that should be possibly offered, preferably in the preconceptional period rather than in pregnancy, because then we have the option of vaccinating for rubella. Now, routine screening for CMV is not recommended by ACOG and SMFM. Toxoplasmosis is not recommended in India. However, as I mentioned, in some countries like France, routine screening is done due to high prevalence of toxoplasmosis. So this particular patient that I mentioned was screened for torch and SSV IgG. And so is there any clinical implication of this particular report? So we need to understand that majority of the neonatal HSV infections, they are acquired at birth as a consequence of direct fetal contact with the infected birth canal or through the ascending infection after premature rupture of membrane. So the HSV component of torch does not really have much of an implication in terms of fetal growth restriction or intrauterine infection. So it is mostly affecting the intrapartum or at the time of delivery. So intrauterine transmission of HSV from the mother to fetus is really rare. So now we move on to the next case, which is a second gravida, previous one abortion at 13 weeks period of gestation. She presents with fever with rash and malaise for 3 days. Her antenatal investigations were all normal and low risk on combined first trimester sweep. And when she came to your clinic with a report of IgM positive and IgG positive for rubella. Now, this is a very difficult situation because we know that rubella is teratogenic. So the next question would be that what should we do about it? So what are the usual manifestations of rubella infections in the mother? In the mother, 50% would be asymptomatic. Now, she came, although this patient had some amount of fever, so 50% would have mild flu-like illness like fever, malaise, lymph nodes, or rash. But majorly mothers are asymptomatic and they are detected if we offer a test for rubella. And reinfection would definitely be subclinical. But what about the manifestations in the fetus? Now, if there is infection in the pregnant mother, there could be infection of the embryo and the fetus, which could result in a miscarriage, a stillbirth, infant born with a congenital rubella syndrome, which has defects which can manifest at birth or defects which can manifest later. The CRS or the congenital rubella syndrome is typically characterized by prenatal ultrasound findings, including the cardiac, the cerebral, the ocular, and at birth typically has cardiac defects with sensorineural deafness and ophthalmic defects. The late manifestations could be endocrine or neurodevelopment. The specificity of ultrasound in diagnosing CRS is 100%, though sensitivity is only 11%. So the crux of the matter is that if there is an early infection with rubella, there is a significant risk of congenital rubella syndrome. But what exactly are the chances of fetal affection? So, in contrast to most viral infections during pregnancy, the risk of fetal infection decreases with increasing gestational age. So, that means that if the infection occurs at less than 11 weeks, in the first trimester, the risk of fetal infection is very, very high. So if a patient is at, say, 10 weeks, there is 90% chance of fetal infection and the fetal defects is 85%. While beyond 23 weeks, the risk is literally 0%. The fetal defects, the risk of infection defects is 0%, and the risk of fetal infection really, really comes down. So rubella infection in the first trimester has a very high chance of fetal infection and fetal defects, and this is something that we really need to consider while counseling our patients. Now, the next question would be that how do we actually know whether the baby is getting affected or not? Because her IgG and IgM both are positive. So, how would we be interpreting this report and how do we proceed? So, we know that IgM would appear within 3 days and disappear in 4 to 12 weeks. However, the most difficult part is that 50% could be false positive. And the diagnosis of acute infection should not be based only on IgM alone. While IgG, it could appear within a week and it could persist throughout life. So how do we actually make a diagnosis of acute infection? And for that, would you like to advise any other test? So there is a testing which is called as the avidity testing. So it can help determine the timing of infection. The high avidity means that the infection has occurred more than 3 months earlier, while low avidity means that the infection was recent within the previous 3 months. So if rubella is IgM or IgG negative, right? So if the IgM and IgG both are negative, so the patient is susceptible. So the patient is not immune, and the patient, however, is also not having an acute infection. If the IgM is negative and IgG positive, this is a very happy situation in which the patient is immune to rubella and we don't have to worry about it. However, if the IgM is positive and IgG is also positive, then we need to actually think about a possible recent infection or a reinfection. Here, the option is do an IgG avidity, and if there is IgG avidity is low, that means it's a recent infection. Also, we can do an IgG titer, and if the titer is rising, then it means that it's a recent infection. In the last situation, when the IgM is positive and IgG is negative, then again it's a recent infection. So these are the 4 possible scenarios in which we can determine from the maternal serology whether the rubella infection is recent. So to confirm the recent rubella infection, a 4-fold rise in IgG antibody titers is important, or an IgG which was negative initially then became positive, or an IgG serology IgM positive with low avidity, or a positive rubella culture, or a viral detection with a PCR in the amniotic fluid is very, very important. So to confirm the diagnosis of fetal infection, we can do an amniocentesis, which is indicated if we have the previous findings of a seroconversion or a low avidity or a very, very strong suggestive findings of ultrasound features of infection. But most importantly, the point here is, when would you do an amniocentesis? It is important that we do the amniocentesis at least 6 weeks after the infection, between 18 to 20 weeks, because before that, there is not adequate viral shedding from the baby. Fetal urine is not formed, so the shedding is not there. So we need to do the amniocentesis at least 6 weeks after the infection at more than 18 to 20 weeks of gestation. So if the infection has occurred between 11 to 18 weeks, it warrants an amniocentesis. If the patient does not opt for it, we can do a serial 4-weekly scans and check the newborn for rubella IgM. If the infection has occurred after 18 to 20 weeks, we have seen that the chances of fetal infection are very, very less. So we can also skip the invasive testing and do a 4-weekly scan. Now, the next question is there a management for maternal and fetal infection? Now, maternal infection is self-limiting, treat the fever symptomatically, And if there is a proven maternal primary infection prior to 12 weeks, we need to explain the high risk of fetal transmission and termination of pregnancy should be offered. For the fetus, there is no treatment available for either prevention to the mother or treatment of fetal infection. So the only mainstay remains the prevention. So to sum up, primary infection in the preconception period, there is no risk of congenital infection. If the infection has occurred between 1 to 12 weeks, there is a high risk of fetal infection. Might need to consider termination of pregnancy. Between 13 to 16 weeks, the risk of fetal infection is around 50% with the risk of congenital defects. So consider fetal testing and termination of pregnancy if the test is positive, or offer termination of pregnancy. Beyond that, there is minimal risk of congenital defects. So consider ultrasound surveillance. Beyond 23 weeks, just ultrasound surveillance is important because the risk of fetal infection is again increases towards 40 weeks, but definitely is less than the first trimester of pregnancy. One important point before we wind up on rubella is, what is the role of vaccination? And do we see a possibility of eradication in the foreseeable future? So, congenital rubella syndrome is still being recognized as the leading vaccine preventable cause of birth defects. And with the introduction of MMR vaccine nationwide in 2017, a mass vaccination campaign targeting children from 9 to 14 years of month was launched. So all women of childbearing age or presenting for preconception counseling should be advised testing for rubella. And if she is non-immune, vaccination should be suggested. Pregnancy should be avoided for a month after vaccination. Women who are found to be non-immune during pregnancy should be vaccinated in the postpartum period, and breastfeeding is not a contraindication to rubella vaccine. And also, those who conceive after rubella vaccine do not need to terminate this pregnancy. So in this particular pregnancy, repeat testing for IgM and IgG and avidity was done. So IgG titer was positive and rising. Avidity was low. So this particular couple opted for MTP. So now we come to the third case, which is a 24-year-old lady who was a second gravida, para-1 live-1 at 33 weeks of gestation with history of fever and myalgia 2 to 3 weeks back. So ultrasound showed fetal ascites and polyhydramnios with a normal middle cerebral artery peak systolic velocity. So there was no fetal anemia, and ICT was also negative. So she had presented with ascites and polyhydramnios. And when the TORCH testing was done, toxoplasma, IgM and IgG turned out to be positive. Now, is this report relevant, and what is the prevalence of toxoplasmosis in India? Is it a real problem? If we actually looked at the reports of toxoplasmosis in India, in a North Indian cohort of women with pregnancy at less than 4 months duration, the seroprevalence was as high as 45% with an incident rate of less than 3%. And it is estimated that around 3 lakh children are born with congenital toxoplasmosis in India per year. And this is a paper by Sarman Singh from AIMS, and he's done a lot of work on toxoplasmosis. So there is a significant amount of prevalence of congenital toxoplasmosis. So this mother gives a history of fever with myalgia 2 to 3 weeks back. So what is the usual presentation of toxoplasmosis in mother, and could this episode be attributed to toxoplasmosis? So it has been seen that most of the infection in toxoplasmosis is asymptomatic, and the remainder have mild flu-like illness with malaise, low-grade fever, headache, and lymph nodes. Fetal ultrasound in this patient showed ascites in the absence of anemia. Now, could it be attributed to toxoplasmosis? So what we would like to understand is, what are the fetal and neonatal manifestations of congenital toxoplasmosis? Why are we worried? What are the features of congenital toxoplasmosis? The main sequelae of congenital toxoplasmosis are essentially CNS manifestations, which include microcephaly, hydrocephalus, and ventriculomegaly, and chorioretinitis and developmental delay. In certain amount of cases, there could be hepatosplenomegaly, anemia, rash, and jaundice. Most infected infants do not have clinical signs of infection at birth, and up to 90% will develop sequelae later in life. So this is something which is very, very significant consequence of congenital toxoplasmosis. So this patient is currently in her third trimester with a possible fetal infection. So what is the chance of fetal infection which progresses with gestation? So overall risk of congenital toxoplasmosis following maternal infection ranges from 20 to 50% without treatment. Here it is important to understand, like, unlike rubella, the risk of congenital infection increases with gestation, which is around 6% at 13 weeks to 72% at 36 weeks. But the risk of fetal affection, like the risk of baby developing problems, is more if the fetal infection is there in the first trimester, while the baby getting affected is less if the infection occurs in the third trimester. So this is understandable because early on there is organogenesis which is happening. So if the fetal infection occurs, the sequelae are more in the first trimester, but the risk of getting affected is less. So this is a concept that really needs to be understood and should be remembered. Her serology showed IgM and IgG positive. So again, how do you interpret the report and diagnose a maternal toxoplasmosis? So again, we need to know that IgM is the first antibody to rise, and highest level is after about 1 month after infection. It is stable for about 1 more month and then decreases. It is not particularly helpful for timing infection, but then IgM can also persist for months, while IgG is detectable after 2 weeks, maximum level after 3 months, and a change in level or repeat testing can determine the timing of infection. Most important aspect about toxoplasmosis testing is that the test should be performed in an experienced reference toxoplasmosis laboratory, which in India is the Toxoplasmosis Reference Lab at the Department of Lab Medicine at AIIMS, New Delhi. So we need to understand that every toxoplasmosis testing may not be standardized because the results are very, very dependent on the lab from which it has been done. So if we are having some confusion, it can be sent to reference laboratories. A list of relevant labs can be available, can be accessed from the internet. Now, is there a role of avidity testing in this case? Again, high avidity means primary infection occurring more than 4 to 5 months earlier, or low avidity means it is, however, is not a confirmatory test for recent infection. And before initiation of patient management for acute toxoplasmosis, IgM positive should be verified by a reference lab. So if there is one feature which is very, very peculiar to toxoplasmosis is the problems with labs, standardization of labs, and that is something that should be remembered, that a reference laboratory testing is very, very important for toxoplasmosis. So if we look at the serology interpretation, if we have IgM positive and IgG negative, we need to repeat after 2 weeks. If the IgM remains positive, IgG remains negative, so IgM is false positive because there was no seroconversion. IgG did not become positive, so this is a false positive. However, if the IgM remains positive and IgG now becomes positive, then it is to be sent to the reference lab because this could be a seroconversion and this could be an acute infection happening. In the second scenario, when the IgM is positive, IgG is also positive, then again we need to send to the reference lab to test for the, because in this particular situation, we will need an avidity testing of the IgG. In the third case, where the IgM is negative and IgG is positive, so in this particular case, this is not an acute infection. In the first and second trimester, it is possible that a pre-pregnancy infection may have occurred and this will not affect the outcome. However, in the third trimester, the interpretation might become difficult because infection might have occurred in the first trimester. So now you have sent the sample to the reference lab, and the sample shows that the maternal infection IgG avidity was low. So according to us, we know that it's a recent infection. So now the mother has a recent toxoplasmosis infection. So how would you establish the diagnosis of fetal toxoplasmosis? So what is the role of ultrasound? Again, the non-specific findings starting from the CNS would be ventriculomegaly, hydrocephalus, intracranial bleeding or calcification, microcephaly. Moving on to ascites, like this patient had hydrops, hepatosplenomegaly, growth restriction, and cataract. Limited evidence indicates that if there are cerebral echogenic lesions, then the prognosis is adverse. While if there are no CNS lesions, the outcome is better. Is there a role of amniocentesis? So, if we are suspecting fetal infection, it is important to do a toxoplasmosis DNA PCR of the amniotic fluid, but it should be delayed until after 18 weeks again, because fetal urine production is well established, and at least 4 weeks after the maternal infection. So, sensitivity is at 90%, and false negative might be because of low level of toxoplasmosis DNA in the amniotic fluid. So, if we are suspecting a fetal infection following a confirmed maternal infection, then in that case, we have to confirm our diagnosis by doing a amniotic fluid PCR. Is there a role of ultrasound MRI if amniocentesis did not show fetal infection? Sometimes there might be a false negative amniocentesis, and serial follow-up ultrasound of the fetus is indicated. Fetal MRI is sometimes better if we are suspecting brain abnormality. If ultrasound and MRI are normal, we know that the neonatal significant sequelae is low. However, there could be an ocular sequelae which is important. So, counseling to this effect remains very, very important. Now we come to the next stage where now maternal infection is there, the fetal infection is there, and the amniocentesis also has come positive. So how will you manage further? If the patient is before 18 weeks, we have to start the patient on spiramycin without delay till amniocentesis, which is given as 1 gram spiramycin orally TDS. Earlier treatment may reduce fetal infection. After 18 weeks, we will immediately do amniocentesis, and if no fetal affection, we will continue spiramycin to prevent fetal affection. If, however, there is a proven fetal affection, then we start the fetal treatment protocol, which is pyrimethamine plus sulfadiazine plus folinic acid, 50 milligram weekly throughout the pregnancy, and the infant is treated for 1 further year. So this is the fetal treatment protocol. So here we need to understand that the spiramycin is given to the mother for prevention of mother to child transmission. And once the fetal infection is confirmed by amniocentesis, then we start the patient on pyrimethamine plus sulfadiazine plus folinic acid, which is continued throughout pregnancy, and the infant is treated for 1 more year. Now, in this patient, a combination of pyrimethamine and sulfadiazine was started to treat the fetal infection, and the baby, the outcome was a baby girl at 2.5 kgs at 36 weeks plus 5 days by emergency cesarean section. The neonate was treated by pyrimethamine and sulfadoxine, and eye examination was normal. So, with this, we come to the next case, which is primigravida presented at 33 weeks with the combined first trimester screen, which was low risk. NTNB was normal, and no routine antenatal care follow-up. Now, she came at ultrasound of 32 weeks, which showed severe ventriculomegaly, dilated third lateral and ventricles, and periventricular cysts. Fetal MRI showed dilatation of the occipital horns of the lateral ventricle and dilatation of the third ventricle. There were a few periventricular hyperintense cystic areas in the gangliocapsular region suggestive of gliosis, and there was partial callosal agenesis. When we did the torch test, the CMV IgM was normal, IgG was positive, avidity was high. Now, the point here that we would like to know now is CMV is one of the commonest torch infections. So, should we be worried about this infection in this particular case, or what is the magnitude of CMV in pregnancies. CMV is the most common viral cause of congenital infection and affects about 0.2 to 2% of all live births. It is the leading non-genetic cause of sensory neural hearing loss and a major cause of neurological disability. 10 to 15% with congenital CMV will be symptomatic at birth, and 25% will have long-term impairment. So, what are the factors which influence the degree of fetal affection? So we need to know whether it's a primary or non-primary and what is the period of gestation of affection. So if it's a primary infection, the risk of fetal affection is 30 to 40%, while it's a non-primary, it is 1 to 2%. If it's a first trimester, the risk is 30% with a long-term sequelae. If it's a third trimester, the risk is 47% with no long-term sequelae. Now, in this case, IgM is negative, IgG is positive. So how do we interpret this serology? Now we have done torch, we have done rubella. Now coming to CMV, I think we do understand that if the IgM is negative, IgG is positive, we would still need to do an IgG avidity to understand how to go about it. Now there could be problems with IgM is that IgM is not diagnostic, may persist for many months after primary CMV. IgM may be detected during a secondary infection, and there could be cross-reactivity with IgM due to another viral infection. IgM may be detected as a result of non-specific polyclonal stimulation of the immune system. And IgG, CMV-specific IgG testing should be performed in parallel with IgM. And again, low avidity means within 3 months and high avidity means more than 3 months. And again, diagnosis of non-primary CMV can be difficult. So in this case, although the IgM is negative and avidity is high, we cannot still rule out an infection in the early pregnancy. So how can we diagnose fetal CMV? So we know we've followed all the particular rules. We try to interpret that the IgM is negative, avidity is high, but given the ultrasound findings, we cannot still rule out a fetal CMV infection. So what are the findings of fetal CMV? So cranial, again, ventriculomegaly, calcifications, cystic changes, cortical abnormalities. Extracranial would be hepatomegaly, liver calcification, cardiomegaly. Placental would be placentomegaly, placental calcification. So all of these findings are corroborative of a CMV infection. What is the role of amniocentesis? So if we are suspecting, we can diagnose fetal infection by identification of viral DNA in amniotic fluid PCR. The timing of amniocentesis is again at least 8 weeks after maternal infection and after 20 weeks of gestation, because all the time it is important that the fetal urine production is well established for the virus to get secreted into the amniotic fluid. What is the role of MRI? It is complementary, especially when we are suspecting CNS lesions. We need to understand these lesions in detail, and 95% sensitivity for the identification of the CNS lesions. Subtle findings on prenatal MRI are also associated with favorable prognosis. So prenatal prognostic indicators in congenital CMV is gestational age. If the infection occurs in the first trimester, it is a more severe affection. If there are absence of CNS lesions has a better prognosis, it can appear after 3 months. However, it does not rule out a sensory neural hearing loss. And ultrasound plus MRI have 95% sensitivity. Again, lab findings like viral load, fetal IgM, and thrombocytopenia, they can predict, but their role is not very clear. Asymptomatic fetuses will have no ultrasound abnormality, normal cerebral MRI, normal biological pattern. Prognosis is generally good, but there is still a residual risk of sensory neural hearing loss. While if other fetuses do have brain abnormalities, then the prognosis remains uncertain. While severely symptomatic fetuses, the prognosis of this group is poor. Is there any treatment available, and how can you decide when to start? Right now, this is in the research phase, and 2 studies have shown promise with valacyclovir in these pregnancies, but RCTs are needed. So, if the fetal infection is confirmed by amniocentesis at more than 8 weeks after seroconversion, we need to do a detailed ultrasound. If the fetus is asymptomatic, expected management. Moderately symptomatic, we can consider an in utero treatment, and if it is severely symptomatic, then a termination of pregnancy is indicated. So it is only in the moderately symptomatic fetus that we would consider an in utero treatment using valacyclovir. And still, this is something which is experimental, not completely established. I would not go for it very easily unless it's in a research setting. Now, coming to the another case, here she's a 30-year-old priming gravida, 26 weeks gestation. Here she's A positive, ICT negative. However, we see here that the MCA-PSV is raised and fetal echo is normal. The baby has fetal high drop, so there is fetal anemia. So this is something that we would understand. Which intrauterine infection would you implicate as a cause of fetal anemia? We would know that it is parvovirus. If IgM and IgG are positive, what do we do next? So we will go for amniocentesis or ultrasound Doppler for fetal anemia. So here we don't need amniocentesis. We can do ultrasound Doppler for fetal anemia because it is also not a teratogen. It can just cause fetal anemia. Monitoring schedule. We generally monitor patients whom we are suspecting parvovirus infection 1 to 2 weekly, starting 4 weeks after infection till 12 weeks. Because the suppression of the hematopoietic system occurs for 12 weeks, after which there is recovery. Indication for IUT when there is high drops or MCA-PSV is more than 1.5 mmol. Now, this is another very, very common scenario. A 32-year-old priming gravida at 16 weeks of pregnancy with history of fever with pruritic and vesicular rash. Now, this lady has chickenpox and all the antenatal investigations are normal. So, scenario 1 is when the mother has chickenpox. So, what is the risk of fetal affection? So, if the chickenpox occurs at less than 13 weeks, the risk to the baby is 0.5%. Between 13 to 20 weeks, it is 2%. And more than 20 weeks, the risk to the baby is minimal. At more than 36 weeks, it is usually the neonatal infection that happens. So it is around peri-delivery that the risk is more, or at around less than 20 weeks. So between 20 to 36 weeks, the risk is minimal. How do you diagnose fetal infection? We can see for the ultrasound features of fetal varicella syndrome or amniotic fluid PCR. Is there a treatment available? Yes, we can start acyclovir within 24 hours of rash to the mother so that the risk of infection is minimized. Now, the second scenario is when the mother has exposure to her child who has chickenpox. The mother does not have chickenpox herself. So we need to ask the mother whether the mother had chickenpox. So if she had, then no other action is required. So this can be actually elicited by a history or even doing an IgG for varicella. If it is positive, then no further action is required. If she is IgG negative, then we can give varicella immunoglobulin within 10 days of exposure or acyclovir as post-exposure prophylaxis from 7 days after exposure. So if the mother had chickenpox, then no further action. If the mother is varicella non-immune, then you give immunoglobulin within 10 days of exposure on acyclovir as post-exposure prophylaxis from 7 days after exposure. So this is all about TORCH that we would like to, I would like to present today. So to conclude, serology for diagnosis of maternal infection needs to be interpreted very carefully. Definite role of ultrasound in prediction and monitoring of congenital infection. Invasive testing should be done to confirm fetal affection. No drug to prevent perinatal transmission of most congenital infections except toxoplasmosis, and prevention of infection is the mainstay. So thank you very much.